going to talk about fall prevention today. And as our cat in the hat friend is showing us, it's a little bit of balance. We all want to try to stay upright. But some of our older folks don't quite make it. So falls are the #1 cause of fracture and traumatic brain injury in the elderly, #1 cause of emergency department visits, and #1 cause of hospital admissions due to trauma. We're looking at epidemic proportions with people 65 to 79-year-olds. 1/3 of them fall, and over half of 80-year-olds and older fall. This is a costly process. Our federal healthcare system pays about $30 billion in direct healthcare costs alone per year. So that's a lot. I'm not going to read through all the direct medical costs there, but it's not covering those indirect costs such as loss of meaningful things in life. The other thing that really happens is a lot of our older folks lose their independence, they lose their confidence. So we're going to watch a quick video on that.
And I realized that my sense of balance had gone.
I fell in my son's home. I fell down 2 steps.
Lots of my friends have fallen and get hurt, you know.
You walk into a strange place, the lighting is poor, and it's very easy to trip and fall.
So you're apt to say, well, I'd rather stay in today, I'm not going out, you know.
So many of us seem to feel there's no way to keep ourselves from falling except to stay at home, not take any chances, and rely more and more on the help of others. Have we decided that the cost of personal injury is so great it must be avoided at any price? Even at the price of our own well-being?
Okay. So who is falling and why? The World Health Organization said that white, socially isolated women over age 75 are more likely to fall than other groups. These women and anybody who is out in the community who doesn't have a good social support system, they don't have a lot of money and resources, they're not going to get the help that they need. When I speak to community groups, I do talk to them about trying to empower themselves to get good, reliable, affordable transportation, good access to medical care, making sure they have access to places to exercise and places to meet people and socialize. Women are 67% more likely to fall than men, more likely to have a non-fatal fall, and twice as likely to have a fracture. But men are more likely to fall due to risky behavior. And we often see this in our outpatient clinics. These older guys who are just so used to doing what they always have done, and they don't recognize that it's time to stop. I work a lot with them and try to help them find alternatives. Try to find somebody who can do this for you, but maybe you can give them something in return. So the barter system, maybe you can be the one who's the supervisor and organizing, telling people what to do. So there's lots of different options. Try to work through that. Okay, so Mary Tanetti did an analysis of 33 different studies and came up with the top 17 common risk factors for falling. Once you've fallen, you're more likely to fall again. So having that previous fall. Balance deficits, that makes sense. Impaired muscle strength, not only just from getting older, from strokes, but also vitamin D deficiency. We're going to talk about that in another slide. Having visual impairments, we kind of learned a little bit about that with the niche. The polypharmacy with more than 4 medications. Gain impairments, depression, dizziness. There's lots of reasons for dizziness, orthostasis being a big one. They get dizzy when they stand up. EPPV being another, we're going to talk about that a bit. And then some of the other things on the far column we kind of talked a little bit about. So the more risk factors you have, the likelihood, the chances that you're going to fall also increase. when you're looking at the risk factors, you want to see the patient as a whole too. You want to think about their functional level. So if somebody has urinary incontinence, if it's a young person, not young, well, young, 60-something, and they're getting around okay, and maybe they have a little stress or urge incontinence, it's not the same value of a risk factor as it is with somebody who's older, who's walking very slowly to the bathroom, who really has to feel like they're rushing to get there. So you want to kind of keep in mind that whole patient. So some things that we can do, obviously we want to try to get those medications reduced, and somebody else is going to be talking about medications later. Implement home safety modifications, physical therapy, exercise. We're going to talk about some of these in more detail in a little bit. Footwear, we really want to make sure we look at people's shoes. Women sometimes just don't want to get out of the heels. Let's get them in some more sturdy, supportive shoes. And oftentimes people who have swelling in their feet will try to get bigger shoes so that it will accommodate the swelling, and then what happens is the shoes get longer, and so they have like an inch or two. We're nodding our heads ahead. And so there are some shoes online that you might be able to find that maybe have wider, accommodate wider widths, but not necessarily the longer ones. If they're diabetic, they might be able to get some orthopedic shoes paid for. Oh, I did want to say back here, sorry. Down at the bottom, strive for multifactorial interventions. There's usually a lot of reasons why people are falling, and we want to try to address more than one of those. We want to try to attack fall prevention from many different areas. Okay, so vitamin D deficiency can cause proximal lower extremity muscle weakness. The elderly are prone to this because they're not getting outside, they're not to get their sunshine, they have poor dietary intake, their skin is less thick. They are often going to complain of feelings of tiredness, heaviness in the legs, difficulty with stairs, and sit to stand. A lot of our patients do say this to us, but keep in mind that there may be that underlying vitamin D deficiency. And it's very well supported in the literature, just taking that supplement can help reduce fall risk. But taking it prophylactically does not help. So they have to have that deficiency for it to work. I'm not going to talk about medications right now. We're a little short on time, and we got somebody else talking about that later. So, okay, so BPPV is benign proximal positional vertigo. It's an inner ear disorder where little crystals in the inner ear get dislodged, and they go into a different part of the inner ear. And when the person goes to move, especially quickly, they'll get a feeling of sudden burst of dizziness. Look for this with your patients. If they're just getting on their mats for their knee exercises or whatever, they might just suddenly get dizzy. Look at their eyes and see if they've got some nystagmus. And I'm going to show you a picture of that.
In this positive Dix-Halt Pike, notice that the patient initially has no symptoms, and then after a few seconds, she says she's getting dizzy. Good. This is called the latency.
Stay there. You're doing a good job.
Also notice that after 15 or so seconds, her nystagmus and vertigo improves.
Is it sort of gone away now?
Yeah.
In this slow motion video, you can clearly see that the nystagmus is vertical with upward beating eyes and a torsional component towards the downward, in this case, the left ear.
Okay, so you don't have to worry too much if you can't identify that, because sometimes that's really hard to see. But definitely look to see if you can kind of see it kind of going up, if you can see that eyelid moving, and if there's even nystagmus at all. And it should go away pretty quickly, within 30 seconds, a minute tops. Okay, so that's what you're kind of looking for. And if they do have that, it's a kind of an easy fix. I can treat them, or you guys know how to do that. But just kind of think about screening your patients. When you are screening them, ask, are they dizzy, or notice if they get dizzy when they're working with you. Okay, so home environment modification. I found a website that I thought was really pretty cool. And this, I meant to tell you about your packets. I didn't make a whole copy of this presentation, but if anybody wants a copy, I can tell you how to get one. Let me see. There it is. So complete home safety self. I wanted to find something that was really comprehensive and easy to use. So this is a gigantic PDF. But we kind of cruise through it a little bit. This is kind of what it shows. It goes through different parts of the house and things that could go wrong in them. And so down at the bottom it talks about, lack of railings, unsafe steps, issues of lighting, uneven cracked pavement kind of thing. I'm going to keep going here. Let's see if I can see how to go down. And you go a little bit faster because I'm going to get down to the bottom. I guess your hands don't work very well on your nose. Okay. So here's the laundry room. I like this one too. It's got the clutter issues, no railings on the stairs. But what's nice is at the bottom of the PDF, it does have products that they liked. So the rubber threshold ramp I thought was an interesting idea, is the motion security lamps, foldable ramps, all this cane ice tip. And it kind of tells you the names of these products. Motion sensing LED light, different kinds of things you can use for the home, furniture risers, the step ladder. And then it goes even a little bit farther. So you can access this at home if you want to really look through these things. But it kind of does a before and after. So here's somebody who's kind of small, but a lot of clutter in their front entrance hall for mail. And then after installing a mail catcher, that resolved the problem. So just kind of really nifty things like that. Here's a guy on a regular step ladder with no railings. Adding one with railings is a big help. Painting a contrasting color at the bottom of a stair step. So there are kind of some good ideas in here if you get a chance to look through it.
Is there a link to that?
Yeah, it's in.
Here?
Yeah, it's in your handout. There's a page that says useful websites, and so it's right in there. It's through University of Buffalo. Okay, another intervention. Really simple. Going from the multifocal lenses to just a single focal lens has been shown to reduce falls. Also, just having cataract surgery. So if somebody's really complaining they've got bad cataracts, get them back to their doctor, refer them back in. Makes a big difference. So here at Chelsea Hospital, we think about what we do when somebody falls. A wellness center, professional buildings, you're going to call 911. Gym, in the gym, we're going to have the physician look, send people to ED. You can have a huddle if it looks like something that we need to discuss, and then also remember to put it in your voice report. We also have a fall response team here at the hospital, so if somebody's falling in a public area, in the courtyards, in the main lobby, underneath the canopies, you're going to do that triple overhead 911 page and do the call the fall response team to the area of the fall. The other thing that we have is this free shuttle service, and we have this now outside for our outpatients. We want to make sure that people walking from the hospital into the parking lot or back in for their appointments have access to a shuttle. But when you're walking around the hospital and you see those people who are really just having trouble, offer them some help. Get them a wheelchair, give them your arm, whatever they need. Make sure that you're using your gait belts and use your lifts. Watching for wet floors, some basic things. Okay, so the nurses do, at Chelsea Hospital, we're expected to screen every patient for fall risk. And that's every discipline, not just PT. So for the nurses, they do nursing assessments. They use this Morse scale on admission twice a day and after a change in patient status. Then with the Morse scale, there's different interventions that they can enter into their power chart. So here's a copy of the Morse scale. Make it a little bit bigger here. So there's 6 different kind of variables that they're looking at. History of falls. So is the person admitted for a fall, or have they had a fall in the last 3 months? Are they admitted with a secondary diagnosis and not just the fall? And as they go through, their scores get higher the more at risk that they are. Are they needing to use an ambulatory aid? Notice that the furniture walkers are scored worse because we know those people are the ones who have poor insight or judgment into how they should fall. Not how they should fall, but how they should be walking. Obviously, IVs, the medications, or maybe even just the fluids that they're getting are going to make them more at risk of having to go to the bathroom more often. They have some gait criteria that they look at, and then the mental status. After they do the gait, they actually have them walk to the bathroom, and they kind of judge them. And at that point, they'll ask them, do you think you're safe to go to the bathroom by yourself? And if they say yes, and they're not, then they get scored for overestimating their limit. So I just wanted to bring that up because I know that they've been using this and I never even really looked to see what they do. Okay, so we also use the yellow wristband. We have the signage outside the doors, bed and chair alarms, placing patients closer to the nursing desk, using sitters. Those are all things that we're trying to do here. So in terms of therapy assessments, now the American Geriatric Society created fall prevention guidelines in 2001. And it's a very comprehensive document. You can go to the website and look at it if you want to. But it was designed to help physicians work their patients through a falls assessment. It does recommend that every patient be screened over 65. For us, we're also, which is again, we're going to observe our patients. Starts at the front door. We're going to look at their gait speed. The PTs learned today that gait speed is a test of physiological health. So if somebody is walking very slowly, because so many body systems come into play with walking, they're walking very slowly, they're more at risk for falling. So if you're looking at that, the need to touch walls or hang on to somebody else, those are all clues to you that this is like a screen that you're doing, that this is something that you're going to maybe need to refer a patient on or do a deeper assessment with them. So the fall prevention guideline by the American Geriatric Society was adopted by the CDC. And the CDC created this STEADY program. It's a STEADY toolkit. Part of this I did put in your packets, but it helps us kind of work through how to do a fall assessment. So the big thing you want to do is ask these questions. Have you had a fall in the past year? Do you feel unsteady when walking or standing? Or are you worried about falling? If those answers are yes, you want to go a little bit deeper and start to do a little bit more of assessment, like a timed up and go or 30-second chair stand. There are PTs I know about that, but OTs also feel free to do some of those tests. And I put some of the forms in your packet. And then after that, it kind of goes into a deeper, even more multifactorial assessment, talking about some of those risk factors that we've already discussed. So I wanted to just take you to that STEADY website. And this is what it looks like. A lot, like over 21 PDFs and different videos. So if you want it, I know I only have a short time to talk today, so if you want to learn more about it, really good resources. There's some patient education materials you can print right off. I printed some of them off for you. The things I like the chair rise exercise. It's a really great simple exercise people can do. The other thing about taking your history when you're talking to your patients, you really want to go over the circumstances of the falls. You want to see if you can try to find a pattern, something that's happening that will help guide you toward your treatment or in different interventions you can take. So where have they fallen? Where are they falling? Are they at church? Are they home? Are they outside? What time of day? Is it night? That means it's dark. Maybe they're having trouble in the dark. They need to use more lights. Maybe it's right around time when they take certain medications, especially for Parkinson's patients, we know they're on those cycles with their medicines. So you want to try to start pinpointing, what is making you fall? We got to figure this out. What are they doing at the time? That's a big one for me. Are they just walking and then turn? Every time I turn the corner in my house, I fall. Okay, well let's look at your vestibular system. Let's look at something else that's going on with you there. Were they able to get up? Do I need to work on floor transfers with them? And of course, were they injured? if they can't remember, and a lot of people can't remember all the details, give them a fall log and put one in your packet and ask them, just fill this out. If you have a near fall or a fall, and we want to start getting some details, because that's going to really help you figure this out. Okay, so functional outcome measures. Now these are instruments that have been studied, researched for validity, reliability, objectivity. These are things that most of us are starting to use to get more of our evidence-based practice going. We want to make sure that we select the right instrument for your patient. The age, diagnosis, functional level are all important in selecting your outcome measure that you want to use. And remember that this is only one part of determining if somebody's at risk for falling. So it's great if the patient does not attest as a fall risk on the Berg, but guess what? Maybe they still have some other home environment problems that are causing the fall. So the Berg is not going to pick up on that. So make sure that you're looking at all of those things. So there's a great resource for us, and I don't know how many of you guys know about this. This is called the Rehabilitation Measures Database, and I'm going to take you to that. This was created by a group of different therapists and researchers who wanted therapists to have access to all the different instruments. And it covers not only PT instruments, OT instruments, but it's got speech and psychological, and I think some even respiratory therapy stuff in here. So what you can do, you can enter in, or if you already know the instrument that you want, you can enter that in. There's a search engine, or you can kind of go down a list and just kind of scroll through. So we're pretty familiar with the Berg balance scale. And basically what will come up is a screen, and it's got all the information that you want to know about that instrument. So it describes the instrument, talks about what kind of equipment you're going to need, how long it will take, the populations that have been tested with this, any kind of norms that are associated with it, and it goes cutoff scores as you go down. Kind of talks about all the retest reliability and retest reliability, all of those things. And it does give recommendations at how good of an instrument it is at the bottom. Not every instrument has been studied as much as the Berg, so you might find some that are listed in here and there's not as much information. But it's a great website to use, and that's also in your packet. Okay, go back. Okay, so the Berg balance scale we did kind of talk about, just mentioned a little bit. Most of us kind of have heard of it or are a little bit familiar with it, but it mostly tests static balance. There's a little bit of dynamic in there. But this is again a tool that you want to pick for the right person. If somebody's very low level, they're gonna not do well on it. They can't do most of the things on it. If they're very high level, there's a ceiling effect, and you're not going to pick up those problems that they're having with walking. So the Berg is a great test, but make sure you pick it for the right person. Anything below 45 is generally the number that we use, but Ann Shumway-Cook also did a study and found some other cutoffs. So if there is a history of fall and the score is less than 51, they're also at a risk for fall, or if there's no history of fall and it's less than 42. And then interestingly, below 40 is 100% risk for falls. The timed up and go we did for competency a few years ago. And just so that you know, there's also a modified tug so that you can do the same tug, standard tug, while the patient is doing something else. So there's a cognitive tug and a manual tug where you're carrying a cup of water. And there are cutoff scores for those two. So if you have somebody that you're thinking is having trouble with some dual tasking, this might be a good test to use. We talked about, the PTs talked about the 10-meter walk, and I did mention about gait speed a little bit, how it's very important to look at the speed of your patient, that they might be at risk for falling. I did include this test in the packet, especially for those of you who didn't get a chance to use it for competency day here, because for OTs it also can measure whether or not they're independent in ADLs. You might be able to know that anyway, but if you need to document things, it's there. Okay, so the best test and the mini best test. The best test was a test created, I think it was by Faye Horak, and it was the Balance Evaluation Systems test. And in that test, she kind of took balance postural control variables, over 6 different variables, and created, basically, I think took portions of like the Berg test, of the dynamic gait test, and some other things, and put it all together in a test. It took like a long time to do, almost an hour. So they created the mini best test, which cut out some of it. And this test is okay. It's got an adequate reliability or validity for picking balls. But just to kind of show you some of the things that there's a sit to stand, rise on toes, stand on one leg, and then this compensatory stepping, which is something that I like, but it's also something kind of scary to do. So you have the patient lean against your hands like for the forward one, and then you let go. And you're trying to see if they take that protective step. Now, obviously, if the person's very big and they don't take a protective step, they could fall. And so you want to be super careful with that one. And that's probably one of the reasons why I don't really like to use this test very much. But I wanted to kind of tell you about it in case you've heard of it. Dynamic Gait Index is a test that looks a little bit at walking issues and things that people do while they're walking. It's a pretty good test. There is a ceiling effect with it. So it looks at things like gait on level surfaces, change in gait speed, gait with head turns, pivot turning, stepping over obstacles, around obstacles, and climbing stairs. Around obstacles is pretty useless. I don't have anybody who's ever tested badly on that. One person, I think. There is a test that's different from the dynamic gait. We're going to get to that in a minute, but the modified dynamic gait index is a screening tool that can be used. So it's just the first 4 items of the dynamic gait that you can use. And so if patients have trouble with that, then it's just kind of a testing. If you don't have a lot of time, you just want to do a quick screen, this is a nice thing to do. Okay, so functional gait assessment is the test I talked about. It's the modification of the dynamic gait test, and this is the one I've kind of been using a lot lately with the population that I see. It was created to make the dynamic gait a little bit more reliable and also to reduce the ceiling effect with it. And I have been able to pick up some problems on some of those higher level patients. It does correlate well with Bergen gait speed. So the things that they added, so it's got basically the dynamic gait setup, but then they added tandem gait, walking with eyes closed and ambulating backwards. And they also time the gait speed and I think the tandem gait, well, the other ones. So it's kind of a nice test. So if you haven't tried it or looked at it, you may want to give that a try. The performance-oriented mobility, it's also called the POMA, but it's also the 1080. And so Mary Snetti tested this. We're going to just look at it for a second here. Oh, let me do that. So I was thinking about this test, especially for our inpatient therapists and home care therapists. This is a really nice test for the little lower level patients that maybe the Berg isn't going to capture. Because it's really just looking at sitting balance, standing up, looking at the standing balance, how they do if they're nudged, turning around, standing with their eyes closed. It's actually something quite easy you can do up on the floors. It won't take very long, and there's a G code associated with it. So with the POMA, there is the balance portion, and then there's also the gait portion. And that's also pretty easy to do. So you could test, it does have a G code for each portion, so you could do balance and gait together, or you could just do gait or just balance, and you can get a G code for each of those. Okay, so the activity-specific balance confidence scale, this is a kind of subjective test that patients can use as a questionnaire that they fill out how confident they feel during doing certain activities. So looking at how confident are you when you walk around the house, walk up or downstairs, stand on your tiptoes when you reach for something, and you come up with a score, and it helps you determine if they're at risk for falling. But I also like to do this to get patients engaged with their own thinking about how comfortable they like to do things. And so part of what my personal goal is when I'm working with people is I want them to feel better when they're done, and I want them to feel confident when they're done with therapy. So I like to do something that's a little bit a questionnaire like this at the beginning and end so the patients can actually see that they're improving, hopefully. Modified fall self-esteem scale is pretty much the same thing, but it's another one out there in the literature that talks about how confident you are, and there are a few different questions on there. Okay, so let's talk a little bit about interventions now. We're talking about some basic interventions, but thinking about how we set up our programs when we work with people. Home care study was done in 2008, looked at what the home care PTs were doing. Less than half were able to link the risk factors to the interventions or refer patients out to therapy. For outpatient therapists, we didn't do a very good job either. Only half of the patients referred for fall prevention received balance training only one time. So that's kind of a problem because the most effective PT interventions are programs where there's a structured exercise program of balance and strength training, not one or the other, but both. And the episodes of care, now this is a new model, okay? Episodes of care must last 3 months minimum to 12 months, okay? The research, and there's getting to be some really strong research, so if we want to start thinking about evidence-based practice, we need to figure out how we're going to treat people for 3 months, okay? And I have some ideas for us. And a minimum of 50 hours is needed to reduce fall risk. So they need to be working on this balance and strength for 50 hours before they're actually going to be not at risk for falling anymore. And for it to carry over. This was a meta-analysis of 44 different studies. So it's not like just one kind of bad study saying this. This is pretty important. So what is structured exercise? We know this, but do we always do it? Consistency between treatment sessions, getting the same exercises, doing them every session, and making sure that you progress your patient through those exercises. Seems basic, but that's what we want to make sure we do. Make sure that they, you can incorporate it into a home exercise program as well. So here's the paradigm shift. This is the new model that we're thinking of. So typically now we are focused on episodic care. We get the patient, we treat the diagnosis, their infection improves, and they're discharged. We're done, our job's over. Not really the best thing they're finding. What we want to do is have a continuum of care. So we are going to try to improve their function and then use some kind of a bridge program to try to help with that continuum of care, because we know that we can't keep people for a year, right? And we're going to talk about the bridge programs. And then they're discharged to an independent home program or a fitness program. So how are we going to achieve 50 hours of exercise? So what we need to do is try to think about a continuity of care between therapy providers. So it might even, I said home care up here, but it might even start on the inpatient level. Inpatient therapists, do you need 5 minutes? Okay, we're almost there. Okay. Inpatient therapists might be able to start on some of these concepts, carry it over, communicate with your home care therapist to outpatient therapists, and so on. You want to use a validated home exercise program for randomly controlled trials, and I'm going to talk about that in a minute. We're going to try to see if you can carry on your therapy program a little bit longer to advance home exercises, do assessments throughout their month, and also keep working on compliance with them. The patient knows they have to come back to you. They're going to be working on the program hopefully a little bit more. We're going to discharge to independent or community-based programs like the Otago exercise program or Matter of Balance, Tai Chi. These are programs that have been created to improve, improve fall risk. And the Otago program is one I just really want to get through here. This is was created in New Zealand, and it's for people with high to moderate function, and it's actually been adopted by the CDC again. And it's something that a lot of therapists are starting to get into doing. There's an APTA course that offers that you can take for $25, and I'm kind of in the process of trying to take that course myself. And it's a really, really good online course that you can take. It talks a lot about these concepts with fall prevention. But this is something that some facilities and hospital systems are starting to do with getting the home care therapists to start the Otago program and then sending them to outpatient centers to continue with the Otago program, so that we're monitoring our patients, we're keeping our patients longer in our system, and we're trying to then hopefully discharge to a transition program like at the Wellness Center. But right now, there currently aren't very good ones for really low-level balance people, but hopefully we can work on that. Okay, so we're going to skip through these. These are just different ideas that we can do for treatment, and that's it. So, thank you.
Thanks, Audrey.
You're welcome.
Some great references.
Yeah, and I think that's kind of the point within that. You can look a lot of this stuff up. I just kind of want to give you an overview.